Yes, it is visible now.
Okay. Are the slides moving?
Yes, yes.
Okay. We can start, Dr. Jagruti.
Yes, ma'am. So, good evening, everyone. I feel extremely glad to welcome everyone to this much awaited webinar of this webinar series by Nima Obgy Central. Myself, Dr. Jagruti Patil, coordinating today's webinar with Dr. Prajakta Patil, ma'am. Our today's topic is modern aspect of ovulation induction. Before starting our session, I request all the dignitaries and all the participants to take a moment for blessings of Lord Dhanvantari. नमामि धन्वन्तरिमादि देवम् सुरासुरैरवन्दितपादपद्मम् लोके जरारुभयमृत्युनाशनम् दातारमीशम् विविधौषधीनां शङ्खं चक्रं जलौका दधत्तमृतघटम् चारुदुर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्या शुकपरिविलसन् मौलिमं भोजनेत्रं कालाम्बोदोज्ज्वलाङ्गं तटतटविलसत् चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवन प्रौढदाहाभिनीलम् प्रौढदाहाभिनीलम् प्रौढदाहाभिनीलम्. So may Lord Dhanvantari bless us all with good health and success. May I audible, ma'am?
Yes, yes.
Yes. So let us continue and begin this webinar. On behalf of Nima Central, I welcome all dignitaries and delegates for today's knowledge enhancing session on the topic of modern aspect of ovulation induction by Dr. Rasika Pise Gulhane. First of all, I welcome Dr. Ashutosh Kulkarni sir, President of Nima Central, Dr. U.S. Pandey sir, Secretary of Nima Central, Dr. Shantilal Sharma sir, Treasurer of Nima Central. Then I would like to welcome Dr. Kamini Bhiman ma'am, President of Nima Obgy Central, Dr. Priyanka Nakde ma'am, Secretary of Nima Obgy Central, Dr. Vishnu Bhavne sir, Treasurer of Nima Obgy Central, Dr. Rajesh Utane sir, Convener of Nima Obgy Central. I would also like to welcome Dr. Suhas Herlekar sir, President of Nima Obgy Maharashtra, Dr. Manoj Gaikwad sir, Secretary of Nima Obgy Maharashtra, Dr. Ajiraj Bal sir, Treasurer of Nima Obgy Maharashtra. So before we go further, let me give you a few instructions that are common for all participants. So please keep yourself muted during the session. If your mic found unmuted or disturbing with the speaker's voice, you will be kept either in the waiting room or removed from the session to maintain decorum of the program. If you have any queries or questions, please put your questions in the chat box or raise your hand. Now, I would like to brief everyone here about Nima Obgy agenda. Nima Obgy, that is National Integrated Medical Association Obstetrics and Gynecology Society of India, aims to impart education in supporting and protecting the character, status, and interests of the integrated medical profession in general practitioners and practitioners of Sri Roga and Prasuti Tantra, that is integrated obstetrics and gynecology in India. Our object is to spread knowledge and to foster the education in integrated obstetrics and gynecology, including human reproduction, family welfare, study and research in the field of contraception and other allied problems. Nima Obgy is committed to promote services for betterment of the health of community, especially maternal and child health, prevention of ailments and diseases, their treatment with integrated approach of Indian medicine with modern science. So with this, let us continue with what we have come up today with you, our 33rd webinar in this series. So dear all, as you know, today's topic is modern aspect of ovulation induction. Infertility treatment has taken quantum lead in today's world of ever expanding horizon of science and technology. So, and this ovarian factor contribute about 30 to 40% in the cause of female infertility. So we are here to explore knowledge about the treatment of this factor, that is modern aspect of ovulation induction. Today, we are very lucky to have here with us a distinguished clinician, Dr. Rasika Pisegulhane ma'am. She will guide us through her novel thoughts regarding this topic. So we welcome you, ma'am. We are honored to have here with us. It is my pleasure to introduce all to you, Dr. Rasika Pisegulhane ma'am. Dr. Rasika Pisegulhane ma'am is MBBS MS in obstetrics and gynecology. She has done diploma in ART and reproductive medicine from Germany. Also, she completed diploma in cosmetic gynecology, fellowship in infertility at 21st Century Hospital, Surat, fellowship in obstetrics ultrasound in Wadia Hospital, Mumbai. She was ex-assistant professor at NKP Sarve Institute of Medical Sciences. Currently, she is the director of Medigras Hospital and Inaya IVF, Ramdaspet, Nagpur. Her special interests are treating high-risk pregnancy and infertility. She got many awards such as gold medal in the paper presentation in Nachi conference at Lucknow. She also published case report on spontaneous monochorionic quadra-amniotic pregnancy at Suffolk Journal. So, due respect, I would like to call upon Dr. Rasika Pisegulhane ma'am to start a session on today's topic. Welcome, ma'am.
Thank you so much for the introduction, and thank you so much for having me here. So I shall begin with the topic of ovulation induction, and by the end of this seminar, hopefully we'll be able to know the topic that I'm going to cover are basically what are the factors to be considered before you start ovulation induction, the indications of ovulation induction, how to go about in a patient of infertility when the patient first visits you. Then what are the investigations to be done? What are the different protocols that we follow in patients of ovulation induction, exactly when to give trigger, how to do monitoring in patients of ovulation induction, then what are different kind of drugs, protocols of IVF, and in the end we'll discuss few case scenarios. So let's begin. So basically, ovulation is the journey of female oogonia to become mature oocyte under the influence of many local factors and systemic hormones. Ovulation can be grossly divided into multiple phases, that is follicular recruitment, selection of dominant follicle, maturation of follicle, and ovulation. So these are different ovulatory disorders by WHO group 1, 2, 3. These are hypogonadotropic, hypogonadal anovulation, eugonadotropic, euestrogenic anovulation, hypergonadotropic anovulation, and hyperplatinemic anovulation. And group 2, that is euestrogenic and eugonadotropic anovulation, is most common. I won't get into the details of it. So what are the factors to be considered when you keep the patient for ovulation induction? That is, what is the ovarian reserve of the patient? What was the previous ovarian response if the patient has undergone any cycle of ovulation induction? Then basic hormonal profile, when to give the trigger, and what luteal phase support has to be given are the factors that we should consider before ovulation induction. So these are the indications for ovulation induction, like anovulation, oligovulation, PCOS, patients in luteal phase defect, unexplained infertility. For the timing of ovulation, hyperprolactinemia, hypogonadotropic hypogonadism in patients of IVF, endometriosis. Then before the whenever the patient comes to you in the infertility clinic, so basic history taking is very important. And the points to be covered in history taking are whether the patient is married for how many years, if the infertility is primary, secondary infertility, then if the patient has undergone how many cycles of ovulation induction, if at all she's facing any difficulty in intercourse, how are her menses, if she's having any menstrual issues, then if she is taking any treatment for any endocrinological problems like hypothyroidism, if she has any diabetes, or any basic medical history needs to be taken, surgical history, Then history about the lifestyle, whether the patient is a smoker, the husband is a smoker, or any addictions basically.
मेडिकल का सर्टिफिकेट बना के भेजा आपको फॉरेन में ना जी फॉरेन में
Excuse me. Hello.
Dr. Jagruti, kindly mute.
Yeah. And then if the patient has undergone any ovulation induction in past, how many cycles she has undergone ovulation induction, then basic physical examination of the patient is must. Sexual characteristics, development of sexual characteristics should be seen. PSPV examination should be done. And after this basic evaluation, you would come to know that what all investigations should be done, then how to go about in this patient. Then preliminary evaluation, like the investigations that we need to do is basic CBC, HIV, HbSAg, hormonal profile like serum TSH, prolactin, D2, FSH, LH, E2. These all hormonal profiles to be done. And if at all the patient has undergone previous ovulation induction cycles and patient has not gotten result, then you can go ahead with another investigations like ANA, APLA, anti-TPO. You have to rule out other things as well. Then karyotyping can be done. Then if the patient is a diagnosed case of PCO, then screening of impaired glucose tolerance and diabetes is recommended for all the obese and ovulatory women with PCOS.
Excuse me, ma'am.
Yes.
Ma'am, just see the screen and just tell me when to do the next slide.
Okay. So please shift.
On the
I think
correct slide.
you are on the next slide. I want you to be on the slide. Yeah. Then
This
semen
slide?
analysis. Before you start ovulation induction in any patient, semen analysis is must because males constitute to 50% of infertility. Then tubes are to be evaluated by HSG or sonosalpingography. And a good transvaginal sonography is recommended because you have to see whether there is any pathology in the uterus and how are her ovaries. Day 2 antral follicle count is very important. Please change the slide. Then the decision-making investigations are AMH, that is anti-Mullerian hormone, which gives us an idea of the ovarian reserve in a patient. Then ultrasonography, like I said, is very important. Day 2 antral follicle count has to be seen. Then in PCO patient, hormone parameters and sperm function test. So as you can see, this is a picture of an ovary, PCO ovary. Then this is also a patient of PCO ovary. So now let's come to the drugs that we use in ovulation induction. Clomiphene citrate is the most commonly used drug. Please change the slide. Yeah. Clomiphene citrate is the most commonly used drug. It is a non-steroidal triphenylethylene derivative. It is a selective estrogen receptor modulator. It acts as both estrogen agonist and antagonist. Most of the time, it acts as purely antagonist or anti-estrogen. So it has less desirable anti-estrogenic effects. And the problem with clomiphene citrate is it has an impaired endometrial growth that you'll be able to see in patients of clomiphene citrate. So whenever you're giving clomiphene citrate to any patient, endometrial thickness should be monitored. And if at all you reach a satisfactory endometrial thickness that is between 7 mm to 14 mm, then you should plan for the trigger of the patient. Please change the slide. It is ineffective in hypogonadotropic hypogonadism patients. So please change the slide. Please change the slide. So clomiphene treatment regimes are like it is given orally 50 mg to be started on second or third day of the periods. Then obese women may require higher doses. So when you're giving clomiphene citrate, start with 50 mg of the dose. Call the patient after 5 days. Do a transvaginal sonography. If you see that there's a dominant follicle, then you might not give the dose, and if then continue with the follicular monitoring. And if at all the patient has still there's no dominant follicle seen, then again you can give the dose of 50 mg say for 5 days, or you can even increase the dose in the same cycle or in the subsequent cycle to 100 mg, depending upon the response of your patient. See, there are no set protocols for any ovulation induction. You have to do the scan and you have to decide if there is any dominant follicle. If there is not, increase the dose and give more clomiphene citrate. Then patient is to be monitored by transvaginal sonography, and ovulation trigger should be given by HCG. 5,000 international unit is more than enough if there is one follicle. And when the follicle is 18 to 20 mm of size, you can give the trigger. So as you can see, this is an ovary where a dominant follicle is seen with different several subordinate follicles. Then this is the way, see, whenever you are measuring or whenever you're doing ovulation study, you always have to remember one thing, that by taking measurements, you always have to make there should be a right angle, like you are able to see in this screen. You should always measure it at a right angle. 90 degrees angle should be there. So as per RCOG guideline, it is very important that not more than 6 cycles continuously and not more than 12 cycles in a lifetime should be given to avoid possible risk of ovarian malignancy. So any patient who comes to you who has undergone 6 cycles, don't give her ovulation induction with any other drug. That patient is for IVF. Don't give ovulation induction with clomiphene, or don't give her with letrozole. That patient is meant for IVF. So another which is very commonly used drug, and I think almost all of us must have used this drug, is letrozole. It is an aromatase inhibitor. I won't get into the details of mechanism of action. Letrozole, you can start the drug from day 2 or day 3. Start with a low dose of 2.5 mg once daily. See if call the patient after 5 days. See if there is any dominant follicle. If not, you can increase the dose in the same cycle to 5 mg, and then again call the patient after 5 days and see if there's any dominant follicle, and keep on monitoring the follicle till the time you have achieved the size where you can give the trigger. Aromatase inhibitor can be effective in anovulatory women who fail to ovulate after clomiphene citrate, and also in patients who responded to clomiphene citrate but poor endometrial proliferation. See, with letrozole, the endometrial growth absolutely remains unaffected, and you get a good endometrium, which we don't get with clomiphene citrate. So when to administer HCG? When the leading follicle is of 18 to 20 mm. And if this is a difficulty which we all face in our practice, like the patient cannot come to us on a daily basis, or you may not see the patient that frequently till the day of HCG. So this is something which you should remember, and you can calculate your day of trigger according to this, that the follicle grows at 2 mm per day. So you can calculate accordingly, and you can plan the patient's next visit according to this. Just a minute. Apurva? I'm so sorry, there was a disturbance. So ovulation occurs 14 to 26 hours after LH surge, and ovulation occurs 34 to 36 hours after HCG. So your IUI should be done 36 hours later, or even if you're telling the patient to have planned contact, so it should be told after 36 hours after HCG. So follicles of 14 mm or smaller occasionally ovulate, but the follicle of 15 to 16 mm, 40% chance is there that the follicle will ovulate. In a follicle of 17 to 18 mm, there's a 70% chance, and 19 to 20 mm, there is 80% chance. See, I have seen, like, since I practice IVF more, so I have seen that if at all, because in IVF, we mainly plan for hyperstimulation. So there are few follicles which are not, which they don't grow up to the size of 18 to 20. But because the other follicles are of that size, I have to give the trigger. But I have seen that whenever I do the pickup, whenever I do the ovum retrieval, I do get good oocytes from the follicles which are of 15 to 16 mm or 17 mm. I have received very good oocytes. So in this scenario also, there is a good chance that patient ovulates, the follicle ovulates, if even if it's not of the size of 19 to 20 mm. So before you give trigger, grades of vascularity can be checked around the follicle. If at all there's a 20% follicular circumference is covered with vascularity, then there's a 25% chance of conception. If in grade 2, if, there is 25 to 50% area of follicular circumference is covered, it is grade 3, and grade 2, and 50 to 70% grade 3, and more than 75% grade 4. So the conception rates are higher in grade 3 and grade 4 vascularity. So we get good oocytes if the vascularity around the follicle is more. So I think one slide is deleted, I suppose. Just a minute. Yeah, so there was a slide that I put. I don't know if it's here in the presentation that I have sent you, but it is not there in my presentation. But can you please show the slide? Next slide. Yeah. So induction in PCO patient. So just a minute. Yeah. So if the E2 levels are low, the patient responds well to clomiphene citrate or gonadotropins. If the estrogen is high, it responds well to letrozole. Mostly in PCOS patient, the drug of choice is letrozole. Start with 2.5 mg, because one thing we have to consider before starting induction to PCOS patient is that we always have to start with a low dose, because we don't want hyperstimulated ovaries, and PCO patients are more prone to OHSs. So always, if you're using letrose, if you're using clomiphene, if you're using gonadotropins, till the time you're not doing IVF, of course, you always have to start the patient with low dose. So there's extended letrozole therapy, which is very commonly used in patients with PCOS. Start with 2.5 mg daily from day 1 to day 10 of your menses. And then do the scan and then decide about the trigger. So this is a step-up protocol. If you are using gonadotropins in patients with PCO, start with a low dose, 37.5 to 75 international units per day. Stepwise increase the dose in same cycle or in subsequent cycle. Do the estrogen and USG on day 7. On day 8, if the estrogen is more than 200 or the follicle is more than 10 mm, continue with the same dose. If estrogen or follicle size is not achieved on day 8, increase the dose by 37.5 mg. Like I said, you have to always start with a low dose, and if you're not getting the desired result, increase the dose in the same cycle, or you can increase the dose in the subsequent cycle. So what are the predictors of ovarian response, which is age? If the patient is young, ovarian response will be good. In the patients with elderly patients, the ovarian response is very poor. PCOS patient, the ovarian response may be either ways. There are patients with resistant polycystic ovary as well. Then in obesity, the patient's response is very less. You need to start with higher doses. Then ovarian response test is very important. If less antral follicle count, the response is poor. If the AMH is less, response is poor. And how is the past performance in the cycles that you have conducted before? It also plays a very important role in predictor of ovarian response. Like, you will be able to decide on the dose better. So these are the drugs that are commonly used to stimulate the patients. That is urinary HMG, urinary FSH, highly purified FSH, urinary HCG, then recombinant FSH, recombinant LH, recombinant HCG, GnRH agonists, and antagonists. These are the commonly used drugs. So recombinant FSH is very commonly used these days. But recombinant FSH, if with recombinant FSH, you can say that the oocyte quality and it is said that the oocyte quality and the take-home baby rate is the same if at all you stimulate with other drugs. But for me, like from my experience, I've seen like these are given in the studies, what I just said before, but in my experience, recombinant FSH gives better oocytes and the pregnancy rates are better, at least what I have seen in my patients. So please change the slide. So before giving any kind of stimulation in patients, preliminary suppressive therapy or downregulation is practiced very frequently these days. Basically, anovulation reflects a dysfunctional HPO axis. So it is important to give in patients like of you can say of irregular cycles, or in patients of PCO, you can give downregulation by either estrogen followed by progesterone, either by OC pills, or even these days you can downregulate the patient. Like if I have kept a patient for IVF and on day 2 or day 3 of the cycle, if at all I find a cyst or a follicle which is more than 0.9 or 0.8 centimeters, so I can immediately give the patient antagonist for 3 to 4 days. And then I can start the patient stimulation. So basically, this is preliminary suppressive therapy. Because if the ovaries are downregulated better, you get a good response to ovulation induction. And if at all there is if you have given suppressive therapy, it suppresses the LH and androgen levels good in patient of PCOS. So you get good response. So if you downregulate the patient before, the ovulation rates increases to 70% and cumulative pregnancy rates increases to 50%. Alternatively, you can give a GnRH agonist also, alternate to your OC pills or estrogen followed by progesterone, or like I said, antagonist is also used these days. And GnRH agonist is long acting also, so it helps us to plan a batch cycle of a patient. You can downregulate, you can keep the patient downregulated, and then if at all I want to do the batch XC or a batch cycle, I can pick up the cycle of the patient whenever I want. So it helps us that ways. Please change the slide. So what indications of gonadotropin treatment are in hypogonadotropic hypogonadism, in clomiphene resistant patient, unexplained unfit fertility, which is very commonly seen these days. You can use gonadotropin. So GnRH agonist, we all know that GnRH agonist has a flare-up action, and then there is a downregulation. So it comes in the form of subcutaneous daily injections, sustained release implants, depot preparation, nasal sprays. But for us as infertility, who are practicing infertility, mostly depot preparations are used, and you can give it subcutaneously as a trigger for ovulation induction, for ovulation, you can give it as a trigger. If you're giving a double trigger, you can give agonist plus HCG. So there are advantages like of agonist, that there is abolition of spontaneous alert search. You don't need to worry, because in patients in whom we have stimulated the cycle with agonist, we don't need to add an antagonist in that cycle, because already the hormones are suppressed. There are reduced cancellation rates. Increased number of oocytes and embryos are seen. Group XC can be done. Like I said, that if I want to plan a batch of IVF, then I can downregulate the patient with agonist, and then I can start with the ovulation whenever we are ready. And less ovarian hyperstimulation is seen. Then disadvantages are that there is obviously increased need of gonadotropin. It might interfere with embryo development in luteal phase. Then functional cysts are seen because it has initial flare-up effect, and estrogen deprivation symptoms are seen because of, if you are using it for prolonged, then estrogen deprivation symptoms are seen. So GnRH antagonist, which is very commonly used drug these days, almost all IVF centers are using antagonist protocol only, and cetrorelix and ganirelix are the drugs used. So the advantages are the symptoms of hypoestrogenemia are rare. Then prolonged treatment for downregulation is not required. Reduced cancellation rates. Then total cycle duration is shorter. If you start the patient with antagonist cycle, I think you are just free within some 13 to 14 days, your cycle is over for that patient. Now let's come to the protocols. This is a long protocol, GnRH agonist protocol. In this, you can either start with the long follicular phase, give the agonist on day 2 of the previous cycle. Then from the next cycle of the day 2, you can start giving the patient hormones, gonadotropins. Or long luteal, like you can give this patient agonist on previous cycle day 21. And from the day 2 of the cycle, you can add FSH, HMG, and trigger when the follicle is matured. Then long protocol is mostly used for the patients who are normal responders. Long protocol you cannot use in the patients of poor ovarian reserve. It is not very favorable for those patients. Then short protocol. Short protocol is used for low ovarian reserve or poor responders. Because of, like I said, that in agonist, there is initial flare-up effect. So this phenomena comes in the favor of the short protocol, because if you give for initial few days, it gives us more number of follicles. It gives us much more cohort of follicles. And then from there, you can start adding from the day 2 of the cycle, day 2, day 3, you can start adding FSH. And trigger whenever the follicle comes around 18 mm to 20 mm. Then ultra short protocol is used for very poor ovarian reserve patients. In this, the agonist is only given from day 2 to day 4. Then FSH is added from day 3 till the dominant follicle is of 18 mm. And trigger, you have to give it HCG, 10,000 international unit, whenever the follicles are mature, around 18 to 20 mm. I think in your slide, this is not coming. I don't know why.
Yeah, I'm able to see only 2 lines.
Yeah, I just noticed that but I don't know why, but in my, I have made a good table for the protocols, but I guess it's not visible only. Can you please show me the earlier slides? Before that also? Oh my God, like all the tables are not seen, but I can see them in my slide. I can resend you again, like after this is over for the reference.
Yes, you can resend, ma'am, or you can just share the screenshots also. That is also
okay. I'll share the screenshots. I don't know why it's not coming the tables, because I've written all the protocols in the form of table when to do what, but it's not visible. in the slide. Okay, anyways. Please, yeah, now antagonist protocol. It is almost all the IVF centers are using antagonist protocol these days. It is a very commonly used protocol. It is used for good and hyper-responder patients. So you first have to downregulate the patient well, preliminary suppressive therapies to be given. Start the cycle from day 2. You can use any hormone like recombinant FSH, FSH, urinary FSH, whatever hormone you want to use. Even HMG can be used. Start with a dose of 300. Then after 4 to 5 days, you can call the patient for a scan. If at all you see that the follicle is around 14 mm, so you have to add antagonist at that time. And if you add antagonist, you have to increase the dose of gonadotropins. You have to add.
Hello, ma'am. Dr. Jagruti.
Am I audible?
Yes,
Yes,
ma'am,
yes.
you are audible now.
I don't know from where you guys did not. I was not audible. आपने कहाँ तक सुना?
Ma'am, you were telling about the antagonist protocol and you were explaining the triggers.
Okay. So whenever the follicle is around 18 to 20 mm, like maximum number of follicles, at that time you have to give the trigger with agonist or HCG, or you can also give dual trigger. So this was all about the different protocols that are commonly used in IVF patients. Now I would discuss few case scenarios. Ma'am, can you please change the slide? Yeah. So a 36-year-old married female for 10 years with primary infertility, willing for conception. There is history of hypomenorrhea, history of polymenorrhea. Her cycles are of 1 to 2 days, and AMH is 0.04. On USG, antral follicle count is only 1 to 2 on each side. So this is a patient of poor ovarian reserve. So in patients of poor ovarian reserve, like in this scenario, counseling is a very important part. You have to counsel the patient well. Then after this, you have to start the patient on few drugs, like you can give DHEA, like supplements of antioxidants, start the patient on that. Then this patient is for IVF. You have to either give ultra short protocol, even long protocol can be used in these patients, poor ovarian reserve patients, because long protocol, like I said, it is used for normal responders, but for poor responders, there is preliminary FSH is lot of there. So because of that, if you stimulate these patients, agar aap day 2 pe scan karoge, so you will be able to see follicles which are not synchronous, because in these patients, poor ovarian reserve patient, FSH pehle hi aa jata hai. So in these patients, you can give agonist so that asynchrony is maintained, and then you can pick up the cycle with your gonadotropins. Then ultra short protocol also works in this scenario. Then antagonist protocol. You can use antagonist protocol in this patient. There's no need to start the patient on a higher dose. You can start the patient on 300 dose. And counseling is very important. Like you have to tell that you can only expect 1 or 2 eggs or maximum 3 to 4 eggs. And the cycle success rate won't be that great in this patient. So counseling is very important. Then a 27-year-old married for 4 years, willing for conception. There is history of irregular cycles, weight gain, AMH is 14, on USG multiple follicle on both sides are seen. So since this patient is married for 4 years, and as you can see, this is a case of PCO. So this patient is married for only 4 years. And so in this, you have to first know whether the patient has undergone how many cycles before of ovulation induction. If she has undergone 6 to 8 cycles, this patient is directly for IVF. If no cycles or 1 to 2 cycles, you can start her with Letrose after evaluating her completely, hormonal profiles, then husband semen analysis, HSG, everything should be done. And after that, start the patient on letrozole. Start with a minimum dose of 2.5 mg. Give her for 5 days. Call back the patient again. Do a scan. See if there's any dominant follicle. No dominant follicle. Increase the dose in the same cycle. Do up to 5 mg. Again, call the patient after 5 days. If there's a dominant follicle, continue with the same dose till the time you achieve 18 to 20 mm of follicle. And if there is no dominant follicle, you can again give Letrose 7.5 mg in the same cycle. Or if you want to cancel the cycle, you can cancel the cycle, call back the patient again, and start with a higher dose in the subsequent cycle. And if at all this patient has already undergone 6 to 8 cycles, this patient is for IVF. And these patients respond wonderfully to antagonist protocol, and mostly this kind of a case scenario, 27-year-old female, AMH 14, we get good number of eggs, good quality of eggs, and mostly this patient conceives in the first cycle only of IVF. They don't require many like 2-3 cycles. They just conceive beautifully in one cycle. So this is case scenario 3, a 29-year-old married for 7 years. Menses are normal, AMH is 5, AFC is 7 to 8 on both sides. Husband semen analysis, only 2 million count is there, and only 10% motility. So this is a normal responder patient with male factor infertility. So in this patient, you have to give and antagonist protocol, like I told before, start with 300 mg. And after you retrieve the oocytes, this patient has to undergo ICSI, like intracytoplasmic sperm injection. And this is the way you go about in this patient. And in 2 million sperm count, you cannot keep the patient for IUI also, because no IUI won't work, because IUI ka cutoff is 10 million. So if there's a count of 2 million, then this patient is for IVF. So the take-home messages: ovulation induction is the mainstay in management of infertile couple. Ovulation induction needs to be standardized according to your hormonal profile. Like I said, there are no set protocol ki if there is a patient, aisa hi karna hai. It is not like that. Protocols will keep on changing. The duration of protocols will keep on changing. So it is not same for all the patients of infertility. For every patient, there will be different dose requirement. There will be different days that she'll take to ovulate. So you have to make your own protocol, standardize it, and you have to go like that. Ovulation induction is an art of balancing between number of eggs versus number of hormonal doses. Thank you so much.
Thank you so much, ma'am, for this wonderful and very informative session. If you permit, could we go for the question and answer session, ma'am?
Yes, please.
So I request all the delegates and participants, if you have any queries or questions, please put your questions in the chat box or raise your hand. Ma'am, I want to ask one query. As clomiphene citrate is strongly contraindicated in presence of impaired liver function, so should we do LFT routinely before prescribing it?
No, routinely, I don't do LFT for any patient of ovulation induction. See, as it is, you are giving the drug only for 5 days, 5 or 10 days. So LFT routinely is not advisable for any patient of ovulation induction.
Okay. Over to you, Prajakta ma'am.
Yes. Ma'am, I wanted to ask then, how would we proceed in a case of endometriosis
Okay.
when we want to do ovulation induction?
See, in patient of endometriosis, the difficulties that you deal with are mainly endometriosis patients are a case of low ovarian reserve. First, you have to see if at all you have to do a good scan of the patient. If there are any other problems with these patients, like if there is endometriomas, if you see that ovaries are stuck in the POD, first, in these kind of patients, you can keep the patient for diagnostic hysterolaparoscopy first. After adhesiolysis, endometrioma resection, you have to again evaluate the patient for her ovarian reserve. These patients are mostly for IVF. And in patients of endometriosis, you have to follow long protocol. So you have to first downregulate the patient so that the endometriosis reduces to some time, and you can even downregulate the patient before you put the patient for surgery. Downregulate the patient, keep the patient for hysterolaparoscopy. After it is done, it is said that after diagnostic hysterolaparoscopy or adhesiolysis in such patients of endometriosis, if you give a rigorous treatment after the surgery, the chances of conception improves.
Correct.
So this is the way you have to go in the patients of endometriosis. Downregulation is very important.
Yes, thank you, ma'am. I would like to encourage all the delegates to put the queries in the chat box. Ma'am is with us and ma'am has explained everything so beautifully and all the doubts can get cleared. So over to you, Dr. Jagruti.
Ma'am, if patient has known case of infertility with PCOS, what precautions should we take while doing ovulation induction to avoid OHSS?
See, like I said, you always have to start with a low dose.
Okay.
Starting with low dose is a key. If at all you see, like I said, there are no set protocols, but there is one principle for patients of PCOS is that you have to start with a low dose. And if you don't see that the patient is ovulating, then you can increase the dose. And any point of time you see that there are more number of follicles, dominant follicles are developing, just cancel the cycle. Cancel
Or
the
should
cycle.
we do down regulation for 2 cycles and then start the ovulation?
No, it won't help much.
Okay.
Just down regulation, 1 cycle would suffice. There's no rule of 2 or 3 cycles of down regulation. And it won't help you to prevent OHSS. Just start with a low dose and see how the patient was responding.
Okay. Over to you, Dr. Prajakta ma'am.
Yeah, ma'am, I would like to ask one question. After clomiphene citrate, today we have so many drugs which are available. So, as you have already mentioned the indications, but how much clomiphene citrate do you use, ma'am, in your current practice?
I use very less. Like I'm not a very keen user of clomiphene citrate. Letrose is my favorite drug.
Okay, okay. Yes, ma'am.
Because endometrium is I don't face problems with endometrium when I use this letrozole. But with clomiphene citrate, endometrium, there's no growth in the endometrium. Then you have to give drugs so that you reach a desired endometrium for your receptivity.
Correct, correct. Also on this only, I want to ask another question.
Yes.
Many times we face that, even though we say that with letrozole and other drugs, endometrial thickness is maintained, but most times we see that it is not maintained especially after continuous stimulations, after 2-3 cycles, we see that the endometrium is very low compared to the previous cycles. So what drugs can be added in such scenarios?
See, if endometrium is not like around more than 7 mm, or you can add ethinyl estradiol. Start with 2 mg BD. You can see that endometrium is growing. But whenever you're using ethinyl estradiol, you have to make sure that you cannot give that drug from the beginning, because then it will tell your pituitary that there is a lot of estrogen. Then again, it will give a negative feedback and FSH won't come.
Yes.
So then your follicles won't grow. So you have to be very particular that way, is that when you have to introduce your estrogen, whenever you see that the endometrium is not growing properly.
Correct. Yes. Thank you, ma'am. Over to you, Dr. Jagruti.
Ma'am, one question is there. Am I audible?
Yes.
Yes.
Ma'am, how does clomiphene work if FSH level is high in the case of premature ovarian failure? Or is there any cutoff for AMH that we should not go for ovulation induction in that
See,
cases?
as such, there is no cutoff which is given that for this AMH you have to use this drug, this AMH you have to use this drug. See, at times, I would say that more than AMH, you should also rely on your day 2 scan, because most of the times AMH and day 2 scans are contradictory. So if you see good antral follicles, you can start with clomiphene citrate also.
If FSH is high on day 2, then also can we go
If
for
FSH is high, then that patient is of, you can say, अगर FSH बहुत ज़्यादा है, then either she is a premature ovarian failure. So in this case, clomiphene citrate won't act. None of the drugs would act. This patient is for embryo donation, ovarian oocyte donation.
Okay. Yes, and ma'am, should we repeat our hormonal assay while doing ovulation induction for more than 2 or 3 cycles? After that, should we go for the repeat hormonal assay or any other investigation?
See, like I am if you have done your 2 cycles, like just before you are doing a third cycle, there's no need to repeat the tests. If at all the patient is having any kind of thyroid or anything like that, then you might repeat those investigations. But there's no point in repeating FSH LHE2, because I already on day 2, when you start the cycle, if you see that all these, if your antral follicles are down regulated, then the hormones are going to be normal only on day 2. They are going to be on the baseline level only. So there's no need to repeat. If at all you see that all the follicles are downregulated, the ovaries are downregulated, well, there's no need to repeat.
Okay, thank you so much, ma'am. Over to you, Dr. Prajakta, ma'am.
Yes, ma'am. Ma'am, we have one question in the chat box.
Yes.
Please tell about antral follicles during ovulation induction.
Can you please repeat?
Please tell about antral follicles during ovulation induction.
Like I did not get the question exactly. Like
This
antral
you have
follicle.
already explained in the cases which you were saying. You said that if it is 7 to 8 follicles, I think that is what she's asking, depending upon how much antral follicles are there, depending upon how to do ovulation induction.
See, if the patient is a normal responder, if the patient is having 7 to 8 follicles on each ovary, she's a normal responder.
Correct, correct.
And if she's a normal responder, everything is normal. There's no need for IVF. You can directly keep the patient. You can give letrozole. If she's a low ovarian reserve patient, 1 to 2 follicle on each side, she's a poor responder. She's for IVF. If there
Correct.
are more than 12 antral follicle count, ovarian volume is more, this patient is of PCO, then you have
Correct.
to treat the patient likewise.
Correct, correct. Thank you, ma'am. Over to you, Dr. Jagruti.
Ma'am, which treatment is more beneficial? Anti-estrogens are more effective, or the FSH or HMG injections are more beneficial for the ovulation induction?
Ma'am, you're saying about FSH and HMG, or like I did not get the question. I'm sorry.
Ma'am, actually, ओवुलेशन इंडक्शन देना है तो क्लोमिफेन और लेट्रोज ज्यादा बेटर होंगे या एचएमजी देना ज्यादा बेटर होगा? मतलब
See, it completely depends. If a patient is of normal responder, you can start with letrose clomiphene. If you're not, at least try with the basic drugs first. If at all you are not getting result for 2 to 3 cycles with letrose or clomiphene, then what you can do is that you can combine your gonadotropins with letrose or with clomiphene citrate and start with a low dose if you are combining it. And like I said, there's no set protocol. You can either see if at all you're getting a good follicle, like they do a day 5 scan. एक बार आप लेट्रोज दो, see how are the follicles. If you're getting a dominant follicle, and then there's no need to add. Or if you are doing if you have already like done 2 to 3 cycles and you have not gotten a result, then you can directly add HMG. or FSH. And because it is said that with HMG or with gonadotropins and letrose or clomifene treatment combined together, the chance of pregnancy in one cycle or the ovulation जो रहता है, it increases to 30%. The chance of pregnancy increases to 30%. So you can try that. You can
Thank you so
combine.
much. Thank you so much. Over to you, Dr. Prajakta ma'am.
Yes, ma'am, we have one more question in the
Yes.
chat box from Dr. Rupali. So letrozole starting dose is 2.5. So
Yes.
maximum, how much we can increase the dose?
7.5.
Maximum 7.
Yes.
You have already shared that in the presentation also. Yeah.
Yes.
Thank you, ma'am. So I would encourage people to ask doubts. Over to you, Dr. Jagruti.
Ma'am, is absorption of letrose affected by matlab, empty stomach, or at what time it will be more effective?
No, it is not given as such when to give letrose, but I mostly practice it at night.
Okay.
Yeah.
Thank you so much, ma'am. Over to you, Dr. Prajakta ma'am.
Yeah, ma'am, I think all the questions are over and we have completed in due time also. And we had a very wonderful and great evening with you to enhance our knowledge. And definitely, we are going to use all this in our clinical practice. So, I would now like to go forward with the vote of thanks. So, ma'am, should I go forward with it?
Yes, please.
Yeah. So on behalf of Nima Obgy Society Central and Nima Obgy Society Maharashtra body, I, Dr. Prajakta Patil, would like to express my gratitude to Nima Central President, Dr. Ashutosh Kulkarni sir, Secretary Dr. U.S. Pandey sir, Treasurer Dr. Shantilal Sharma sir, for the remarkable support. I extend my gratitude to Nima Obgy Central President Dr. Kamini Dhiman ma'am, Secretary Dr. Priyanka Nakde ma'am, Treasurer Dr. Vishnu Bhavne sir, and Convener Dr. Rajesh Utane sir for supporting and guiding us to conduct today's webinar. I would also like to thank and express my immense gratitude to you, ma'am, to Dr. Rasika Pisegurni, ma'am. Ma'am, it was a very knowledge enhancing and horizon widening session and a wonderful session. So thank you so much, ma'am, that you took time from your schedule and you came here and delivered a wonderful session. And we want you in further sessions also, ma'am. So whenever we would definitely like to hear you very soon. So please be with us. So thank you so much, ma'am. I would further like to extend my gratitude to our Nima Obgy Maharashtra President, Dr. Suhas Hedlekar sir, Secretary Dr. Manoj Gaikwad sir, Treasurer Dr. Ajay Raj, all the support to conduct today's webinar. I would like to thank Dr. Girish Daga sir for all the technical support and help to conduct today's webinar. I wholeheartedly thank all the participants and delegates who are attending today's webinar. Without each and every one of you, these webinars are definitely not possible. So keep on attending and keep on increasing the knowledge. So thank you so much everyone for attending, and we will see you soon. We have a upcoming webinar on 18th of December. So we will all see you soon in that webinar, and hope you all have a great evening ahead and hope you are taking a lot of take home points from today's webinar. So with the permission of all the dignitaries, I will now like to conclude this session. So thank you so much, and everyone can now leave the meeting. Thank you so much, ma'am. And thank you everyone. Thank you, Dr. Jagruti.
Thank you, Prajakta ma'am, and thank you. Thank you, everyone.